Next session. So today we're going to talk about reversible causes of cardiac arrest. So we used to call these the 4 H's and 4 T's, however there are actually more than 8 causes. These both apply to your ability to stop a cardiac arrest and what interventions we can use to give the patient the best chance of survival. So to start off with the H's, and the first H we're going to look at is hypoxia. So in order to alleviate hypoxia in both the deteriorating patient and somebody in cardiac arrest, we have to make sure they have a good airway, and that could be by, in a medical patient, doing the head tilt chin lift, or in a trauma patient doing the jaw thrust, and applying high flow oxygen. So these are critically unwell patients, so we're going to be applying high flow oxygen regardless of oxygen saturations. So we place an oxygen mask on and a ear. Obviously this will be attached to high flow oxygen and a bag, reservoir bag filled. So this will address the hypoxia. The next H is hypothermia, whereas having a low temperature in cardiac arrest can be therapeutic. In a deteriorating patient is not good, and if a person is in cardiac arrest we need to warm them up slowly in order to prevent that deteriorating even further. So in order to lessen loss of body heat, provided we don't need access to the chest, we'll obviously make sure the patient is covered, and cover them with a blanket or a bear hugger or foil sheet to preserve their body heat. So that's our second H. Our third H is hypovolemia, or loss of blood. So if there's external bleeding, we'll be doing measures to stop that bleeding, and that might be the application of a dressing or a tourniquet, or it might be, with the case of internal bleeding, just make sure the patient is supine, laying down and raising the legs to preserve blood into the central core. So our fourth H is hypoglycemia, or metabolic imbalance. So for this we'll need to take a blood sugar if we're looking for hypoglycemia, or with a good history of a diabetic patient in collapse, we may be able to presume hypoglycemia. If it is a diabetic patient, then it's possibly the hyper rather than hypo, but in this case giving them extra sugar wouldn't be as harmful as not giving them sugar if they were hypoglycemic. So sugar can be administered in many forms. With somebody's awake and fully orientated, we can give them a sugary drink. If there's somebody semi-conscious or in a collapsed state, we could try something like glucogel, which is a paste which you could rub into the patient's gums. If that's not effective, we could move on to an IM injection of glucagon, which will release glucose stored in the liver. However, if the patient is exhausted, then that glucose won't exist and the patient will not benefit from the glucagon. Failing that, if we can gain IV access, we can give IV glucose, such as we have here. They only need a very small amount, and this is probably the most effective method, but it requires the skills both to cannulate and set up a drip in order to administer this medication. So those are our 4 H's. There are other metabolic imbalances, but they cannot really be measured outside of hospitals or treated as such, so we'll concentrate on the main ones. Moving on to the T's, our first T is toxins. So if a patient has taken an overdose of medication, there's not a lot we can do about it pre-hospitally unless it's an industrial poison where an antidote exists. However, if it's something like an overdose of opiates, whether it's opiates we've given the patient during their treatment or opiates they've taken for self-medication or for recreational purposes, we can use something such as naloxone, which we have here in both a pre-drawn syringe and an ampule form. So these can be given IM or IV, normally IM or sometimes intranasally, which we'll look at in another video. So that's toxins. Our second T is cardiac tamponade. Now, a cardiac tamponade is blood which is trapped around the layers of the heart. The only way we know if this is a possible diagnosis, if the patient is in a collapsed state, they have a compromised circulation, and when we listen to their chest we hear muffled heart sounds, and that would be a classic sign of a cardiac tamponade. This needs X-ray or ultrasound in order to decompress it, so it's not something we could do outside of the hospital. Our third T is tension pneumothorax. So if when we examine the patient doing our ABCD assessment, we notice one side of the chest was not rising, and upon auscultation we can't hear any breath sounds. What we can do is we can place a large gauge cannula in between the second and third rib, below the second rib on that border, and use that to pierce the skin and release air from that affected side. The patient should have immediate release, and we should see an increase in saturations once that's decompressed. So our final T is thrombus, and thrombus can be of two sorts. It can either be a pulmonary embolism, which a patient might have a history of sudden sharp chest pain and shortness of breath, either during treatment or prior to treatment if it's a cardiac arrest. Again, this needs hospital intervention because it needs some sort of clot busting drug. Or it could be a cardiac thrombus. If that's the case, as in a heart attack or myocardial infarction, and this was a conscious patient, we'd be treating them with 300 milligrams of aspirin, and providing they had a reasonable BP, we'd also be giving them GTN to reduce the preload on the heart and the blood pressure to ease the pain of the cardiac pain they are experiencing. So those are the 8 causes of cardiac arrest. So we can preempt them, we can do preemptive treatment, giving oxygen, stopping bleeding, giving certain drugs to prevent that patient deteriorating any further. And in the case of cardiac arrest of unknown cause, we need to consider all 8 of these and how we might treat them during a patient in cardiac arrest. Thank you very much. Goodbye.